My colleagues will tell you I'm always speaking out of turn, so, oh, you couldn't hear me anyway. My microphone wasn't on. Welcome. Thank you for joining us. I know everyone has had a busy day. We have a few seats in the front and in and about. Please try not to stand in the back. Actually, we're a pretty crowded room now that I see there's a few seats over here, three over here. Don't be shy. Thanks for joining us, and welcome to From Resistance to Resilience, reinforcing the response to AMR. We're very excited and honored to have you all here today. Some very interesting conversations I've been having just to start the evening off, and it's a pressing need that we're addressing to focus on investments and interventions to address antimicrobial resistance. Those of you in the room know a thing or two about AMR, I think, but some of you may be asking and have asked me here, and I know our broader FP audience at home is asking, why AMR? What is the thinking behind that? And so I wanted to explain a little bit about that. It might be old hat, unfortunately, to you folks, but for some of our viewers online, would be interested to know this. First of all, FP has become very involved in the health space, obviously after COVID, which was the most recent giant calamity that forced us as a human race and society to work together, regardless of borders, and solve all those problems together. And we did such a great job of that, right? All together, didn't we? And we realize that this is an incredibly important part of foreign policy. Yes, there are unfortunate wars in Europe, in the Mideast. There's hegemonic conflict happening. There's a lot of things that we cover at FP, but we see this as an incredibly important topic that we want to cover. For the data points that I'm just cribbing from the WHO, and you all know it, 1.27 million global deaths attributed to drug-resistant bacterial infections in 2019. It has huge impacts on animal health, food production, the environment, threatens multiple sustainable development goals, which are near and dear to our hearts as well. And there's a financial impact as well. The World Bank estimates that AMR will result in $1 trillion to $3.4 trillion in losses to gross domestic product annually by 2030, and an additional $1 trillion in health costs by 2050. So this is important, and the spread of AMR increases the risk that common infections become impossible to treat, routine medical procedures become more complicated and unsafe, surgery, cancer treatment, and reverses all the great gains that we've made. So that's an important reason that we're interested in this. But also because I wouldn't say it's solvable. I'll have shoes thrown at me, but we know what the problem is. The problem is misuse and overuse of antimicrobials. And many of them, especially antibiotics, are losing their effectiveness as a result. And there is also an inadequate pipeline of new antibiotics. And research and development needs to be picked up, and there's an urgent need for new measures to ensure equitable access to those new antibiotics as well as existing antibiotics. The other thing that really strikes home for us at FP is that while AMR impacts all societies, first world and third world, it really has its primary impact on lower income and unequal society. So in unhealthy environments that enable the spread of infections, lack of water, sanitation, hygiene, all exacerbate this, and it's a big problem we want to help solve. And also another key tenet that we focus on in FP, climate and the environment is also exacerbating the problem. We really don't even know what the effect is going to be, but it's likely going to accelerate the emergence and spread of AMR. And as I said, it does not know any country border, so it makes sense for all of us to work together. So thank you for all the work that you do. And of course, from a timing perspective, this is the perfect evening to host this discussion, the big day tomorrow, the high-level meeting, which will lead to the high-level meetings this fall. So the crucial question that we want to address tonight is around how we can foster a sustainable and thriving innovation ecosystem that provides access to existing antibiotics and develops new antibiotics to keep pace with AMR. And we are so pleased to be hosting this in partnership with our friends at the International Federation of Pharmaceutical Manufacturers and Associations, IFPMA going forward, henceforth. And they're the body that represents the pharma industry in official discussions with the UN, and they're the perfect partner for us with this discussion. We've gathered experts for you tonight from various fields: government, public health, multilateral agencies, the private sector, to share with you their experiences, their insights, discuss the challenges, the opportunities, innovative challenges, ways that we're responding to AMR. We'll hear perspectives from ambassadors, including one in a minute, and frontline workers. We'll discuss efforts from the private sector on AMR access, antimicrobial access, research, development, and innovation. We'll learn about governance and what we're doing to coordinate the AMR response at the national, regional, and global levels. So I think this will be a really good discussion. We aim to spark thought-provoking conversations at FP. That's what we do with our events, if any of you have attended in past. And we want to help drive meaningful change in global health. That's one of the keys. We normally encourage everyone to ask questions as we go, but we've got such a jam-packed program, I don't know if we'll get around to that. You do have a QR code on the cards on your chairs. You can click through to our event site. You can see the schedule. You can see the speakers' bios, et cetera, in addition to paying attention. And those of you on the live stream page will see all of that as well, in addition to some excellent content that we've done at FP on the topic and on health generally. So do share those insights with us. But we have some of those questions already baked into our program. I'd like to thank in advance our panelists for joining us and making the time, and for you and your interest in participation. So we'll kick right off right now because we've got plenty to talk about. But I want to remind you all that there will be drinks and refreshments at the end of these next couple of hours, hour and a half-ish. So do stick around and try and suppress your thirst. It should be a very interesting conversation. So let's kick it off with our first discussion, if we would. I would like to invite...
Please welcome to the stage the alternate permanent representative of Mexico to the United Nations, Ambassador Alicia Buenrostro Massieu, for a conversation on the current status of the fight against antimicrobial resistance.
Hi, Ambassador, how are you? I guess I should know better at this point to speak when it's not my turn. Ambassador Alicia Buenrostro, thank you so much for joining us tonight. We're very pleased to have you here, and we are looking forward to this discussion. So I want to dig right into it, if that's okay, and we'll see where we can go. So Mexico's efforts to combat AMR have reduced the lethality rate from 6.71% in 2021 to 4.7% in 2023. That is incredible. And I'd love to know what innovations have led to this precipitous decline, and if there's any secret sauce that you can share with the audience here, and if we could talk through some of the learnings on that decline.
Absolutely, and it's a pleasure to be here with you this afternoon. And yes, it's been a long journey for Mexico, but we have been very committed towards AMR. As you know, we are co-chairs of the group of friends and very active in the negotiation. But when it comes to the numbers in Mexico and the policies that we have undertaken, let me tell you that it is a combination of education, of public policies, of policy interventions, and strategic collaboration as well. In 2010, first of all, Mexico initiated compulsory prescriptions, which were very important for antibiotics as part of a broader governmental effort to curtail precisely the indiscriminate use of these drugs, of AMRs.
What was the prior prescription methodology for
antibiotics? Well, it was easier, it was easier for doctors to prescribe, and then over the counter you could be very easily taking the AMRs. And then we saw that we were creating lots of problems, health problems, and a lot of resistance as well. So this was back in 2010, and that's why Mexico decided also to bring this issue to the attention of the United Nations. We thought that it was the only way really to do it on a global scale was to bring it to the UN. And then with Ghana, the UK, and South Africa, who are also members of the group of friends, we have enhanced the attention of the United Nations. But if I come back to my country, I would say that, of course, the prescribing practices among healthcare providers, we were very much on top of them, to control the access of that so that it was not easy at all to get them over the counter. Then in 2018, a few years ago, Mexico escalated its efforts by unveiling a national policy strategy against AMR, signaling a coordinated and multi-sector approach to tackling AMR precisely. And so that was developed in collaboration between various government agencies, with NGOs, with the private sector, and also with several departments of government. Agriculture, of course, which is very important, the National Service of Health, agri-food quality as well, which is the agriculture. And so that we could really address the different facets of the AMR challenge in a comprehensive way. So then, of course, in order to complement and in order to be able to move forward, we implemented educational programs on AMR, which has been a very important component of the strategy. As you can imagine, anything that has to do with education and enhancement of knowledge will render results in the long term. In particular, among health professionals, policymakers, and the general public as well. Then also Mexico established an intersectoral surveillance mechanism to monitor resistance patterns across human health and animal health. And furthermore, my country intensified efforts through prevention and control measures, recognizing the role in our strategy, which involves education, collaboration with different departments of government, public policies that have been implemented. And in parallel, Mexico has prioritized as well the development and implementation of national policies to regulate antimicrobial use, regulatory measures to govern antimicrobial sales, antimicrobial stewardship guidelines for healthcare facilities. And so by addressing all these components, that's why Mexico has been able to move forward and to confront less problems with AMR, to which we attach the greatest importance.
Kudos. Thank you for sharing some of those insights on the elements that Mexico has put in place. I noted that you mentioned education, and there's been a big focus on that. And there's been a partnership with UNAM on putting this forward. I don't know if that's something you could shed a little bit more light on, how much education has played a role in this improvement.
Well, the National University of Mexico is the largest public university in our country. It encompasses around 350,000 students. And it's the main center for research in Mexico as well. So with UNAM, we have been able to develop a strategy in terms of education and courses. And it has been mainly, very complete and full courses that are provided to students, but also to the private sector and also to the healthcare sector as well. And it has worked out very well, in particular because through UNAM, we have been able to reach out in a big scale. Imagine that Mexico has a population of 130 million people, but through the university and the courses that have been implemented with a lot of success, we have been able to reach out and be able to educate and to increase the knowledge on the problems that AMR causes.
So university is a great way to get through to the widest group possible. You mentioned the group of friends on tackling AMR. Mexico's co-chair of the group. I would love if you could share with us a little bit about the group. It's world leaders working together to accelerate political action. Would love to hear a little bit about how this convening has strengthened global political momentum, if you had any examples.
Sure, absolutely. One of the ways in which we work at the United Nations is also, that there are you have the principal bodies of the UN, but you also have the work of that it's done through the first, second, third, fourth, fifth, and sixth committees. But at the same time, there are also some other tools, outside tools, that work within the UN, but that are independent from the internal work of the UN. But however, these are very important, and these are the group of friends. And as we said, the same way in which Mexico brought for the first time to the United Nations 4 or 5 years ago the issue of innovation and digital technologies to the attention of the United Nations at the time when we were seeing that there was a lot of development in this area, we also decided that for AMR it was important. So we launched this group of friends, and the group of friends enable really you to get in touch with other stakeholders of a particular file or a particular issue like AMR. And this enables you to organize different meetings and different kind of layers of reaching out and establishing relationships with between the NGOs and the private sector and health providers and so on. And in this regard, you are able really to realize the importance of the problem and what lies underneath and what are the challenges that we face and how we can really improve. So with Ghana, with the United Kingdom, in particular with the UK, we have been very active in AMR, but also with Ghana, who is also a member, and China and South Africa, we have been able to work closely together, but at the same time with other stakeholders that are knowledgeable on this, and then we are able really to get to know each other, listen from the private sector, the problems, for example, at the facilities, the fact that there are many developers of antibiotics that are living after dedicating their lives for 60 years or 50 years, in research and so on, and how it has been also very difficult, for example, to get some other professionals, young professionals, to come to the industry and to develop new antibiotics. So one of the beauties as well of working with the group of friends is that you can elevate the attention of a particular file like this one, or as it has been the case of artificial intelligence more recently as well. The group of friends enable, when you share a particular concern like AMR, you can share the best practices that those countries that are members of the group of friends are doing or undertaking, in this regard. What has really worked out for some country or which hasn't for another one, and so on. So it's about also sharing experiences, sharing resources, and then leading to the development, of course, of more strategic and effective strategies and policies. And then also it enables to advocate for increased political attention among global leaders as well, and resources domestically and internationally. We know how expensive is the production of new antibiotics as well. So in this regard, the group of friends can really target, can really identify, can really be able to move in different ways and try to strategize an issue that represents a big challenge in terms of health for the whole population of the world. And then, of course, the sense of responsibility, something that we are sharing together, that this is an issue that concerns all the human beings, and solidarity as well. So those could be like the main elements that I would mention when you have a group of friends.
Great, thank you. We only have a minute and a half left, and I promise I'm not getting political on you, but there's an election in Mexico in a couple of weeks. You know about that.
Yeah.
And we did a story at FP that is actually top of our site today. You could look at it right now on Claudia Sheinbaum.
Yeah.
And we're not, again, there's no politics in here because she's the presumptive. But I would be interested to know from your understanding, your position, how big a priority this is within the government. You just talked about working with other governments, with the group of friends. There's many priorities, obviously, to tackle, but understanding her, and this profile that we wrote, and I'll send it to you if you forget, so you can check it out, talks about her focus much more so than AMLO on the environment, on women's issues, things around this kind of health space. And so, yes, I'm asking a little bit about your opinion on whether this will be carried forward in the new administration.
Okay, very good. Let me respond to you in a minute and a half that we have. First of all, this will be the general election that will take place on the 2nd of June. We will have a woman in Mexico as president. Whoever wins.
That's correct. Whoever wins.
Will be the first time in history I was telling this morning to an audience that in 1953 was the first time that women in Mexico were able to elect and somebody and vote for somebody. So in this case, we have the leader of the opposition, the candidate from the opposition, and the candidate who is an engineer, and the candidate from the official political party that is in power is also a biologist. So both of them are very much committed towards this. I would say Mexico is one of the countries that has undertaken a feminist foreign policy. The elections that will take place on the 2nd of June will be supervised by the Instituto Nacional Electoral, which is an autonomous body, an independent body, who is presided over by a woman. The president of the Supreme Court of Justice is a woman. The president of the Chamber of Deputies and Senate are women. Our foreign minister is a woman, and she might also be a candidate to become the next Secretary General of the United Nations, and we need a woman there, and we have a very well-prepared one. So when it comes to women issues, when it comes to environmental issues, and when it comes to AMR, it would be an absolute priority, and I will tell you why. Because women, we are on top of these issues, and we care about them. So I'm pretty sure that all the public policies that would be implemented by the government of Mexico, whomever wins, we will continue with these policies. But of course, we need, the international community, and what we do at work at the United Nations helps a lot, because the way in which you do foreign policy internationally, it's also a way of pushing internal changes in your country. So you use also international policy that is being created at the United Nations level to also exactly foster public policies in Mexico.
Wonderful.
National.
Appreciate that. Thank you so much, Ambassador.
Andrew, thank you. Thank you.
Please now welcome to the stage Infectious Diseases Society of America's Senior Vice President, Amanda Jezik, for a conversation with FP's Executive Vice President, Allison Carlson, to hear the frontline workers' perspective on AMR.
Thank you for joining us.
My pleasure. Thank you for having me.
And thank you to the ambassador and to all of you for joining us here in the room, and to everyone who is joining us online around the world. We really appreciate you taking the time to discuss an incredibly important issue that does not get enough attention. We just heard about the incredible role of women in addressing AMR, and also the role of governments and governance. And I think it's really important also to shed a light on the human experience and the human face of how AMR is affecting people around the world. And so I'm really excited to have the opportunity to talk to you and learn from your experience. And, AMR risk compromising medical gains that have occurred, across decades. And also it's making what are relatively simple medical treatments more difficult to treat. And AMR is increasingly putting them at risk. And so from your work and with the Infectious Disease Society of America, how are you seeing this manifest? You're working with physicians, doctors, scientists, and are very much on the front lines of this. And so if you could capture that for us and for our audience, so that we can all understand a little bit more how this is showing up every day.
Absolutely. So I think first it's so important to understand that antibiotics are really fun procedures that we have all come to depend upon: cancer chemotherapy, surgeries, organ transplants, C-sections, hip replacements, knee replacements. I could go on and on. They all carry a risk of infection, and physicians have been able to be very bold in driving all of these types of progress forward, because we've had antibiotics to fall back on to make these healthcare procedures safe. And as antibiotics are losing their effectiveness, these healthcare procedures are becoming more and more dangerous. And I think where that shows up every day is when clinicians have to tell their patients, I'm sorry, we don't have something that will treat this infection. or when clinicians have to deny a patient a life-saving organ transplant because they know it won't be safe to do. And I think that is something that our members and I think healthcare workers across the world find unacceptable, and that's why we're calling for more action on AMR.
What role do physicians have to play as part of this, and those who are prescribing antibiotics? I think there's a very important question around stewardship, and what role do they have to play from your perspective, and also those who you're working with?
Absolutely. So we know that overuse of antibiotics is driving this problem. And so I think there's been a lot of attention to using antibiotics wisely. Stewardship is really about making sure patients get the right drug for the right bug, the right dose, the right duration, and making sure that people who don't need an antibiotic don't get one. And I think that it's important for clinicians not only to prescribe accurately, but to help inform their patients and their communities about why we're trying to use antibiotics more wisely. And it's not just about resistance. Antibiotic use can have adverse effects on individuals as well, which is something that I think is not as well understood. I think the other really important role for healthcare professionals is not only in their day-to-day practice, but as advocates. And that means working at a global level to help inform, decisions and activities, as well as within their own countries, really trying to drive progress with their own Congress or Parliament or health ministers to help them understand what are the challenges on the front lines.
What are some of the key interventions related to access? You're working in a number of different communities, large cities, rural areas as well. And so when we think about access and we think about antibiotics and this overlay of AMR and the impacts, what are some of the key areas that need to be focused on?
Absolutely. I think, first we need to make sure that we have a strong healthcare workforce, and particularly a workforce trained in infectious disease, so that patients who have infections or who are at risk infections because of their underlying health conditions can be able to see someone who can prescribe them what they need and make sure that we can ideally prevent infections in the first place and be able to diagnose and treat them rapidly and appropriately. Then, of course, we also need access to the antibiotics themselves. And I think that is really a combination of both access and innovation. You can't access a drug that doesn't exist because nobody wants to make it. So we've got to drive innovation, and we need to do so in a way that promotes, appropriate access and that promotes good stewardship. And I think that a number of countries talking about something called subscription models, maybe we could talk about a little more, is a really important, innovative way to drive sustainable innovation that also aligns with stewardship and access.
Great. Stick around, everybody, because we are going to dive into subscription models and also trade-offs with different incentives and models. I'm curious as well, when we're talking about this issue and focusing on AMR amid a number of other challenges, global health priorities, limited funding, et cetera, why should we focus on this now? And when we were talking before, this question about the cost of inaction came up. And so when we think about the cost of interventions and the investment that's needed, which we'll dive into, how would you characterize the cost of inaction?
So I think there are costs in terms of human lives, and there's cost in terms of economics. On the economic side, for example, in the US, just 6 of the worst pathogens cost our healthcare system in excess of $4 billion every year, because people have to stay in the hospital a much longer time when we can't simply give them a drug that works and send them home. The cost in terms of human lives and in terms of turning back our medical progress. So a couple of examples in the US right now, sepsis, which is the body's overwhelming response to an infection, is the second leading cause of maternal mortality. Young moms are dying because we aren't doing enough on this issue. Infections are estimated to be about 50% of cancer deaths. Again, all of that, innovation and progress that we've made in treating cancer, helping people live longer, we're losing it because we're not investing enough in AMR.
And I feel like this is a real opportunity. We're convening here tonight ahead of the multi-stakeholder meetings tomorrow and in advance, as Andrew was mentioning earlier, of the high-level meetings here alongside the UN General Assembly in September. And so this is a real opportunity, not only for those in the room who are working across industry, government, practitioners, to really learn and think through how to work more effectively together. Here in New York tonight and in advance of the meetings tomorrow, where you sit, what needs to be prioritized?
So I think three things. Urgency. We've got to move quickly. Secondly, bold, actionable targets. As we were putting together that political declaration, it can't just be a lot of nice words about AMR is important. We need really clear, strong metrics so that we can hold ourselves accountable and move forward in the coming years. And I think thirdly, it can't just be about what happens here in New York. It has to be about what all of us do when we go home. And I know for our members who are primarily based in the US, we are always advocating to the US Congress, we need to pass the PASTOR Act. That's our subscription model bill. We need to invest in our public health infrastructure. And we need to do our part as one of the high-income countries to help finance change around the world.
Thank you for that. And it's interesting what's happening in this country, but also what we have to learn from others around the world in terms of models, policies, incentives that are being implemented, and really harnessing and focusing in on what's working and what can we all learn from each other. So thank you. But appreciate you being with us tonight and for the work that you're doing.
Thank you.
Please welcome James Anderson, the Global Health Executive Director of the International Federation of Pharmaceutical Manufacturers and Associations, to discuss the future antibiotic pipeline.
Great. Hi, James. Thank you for joining us, and thank you for your partnership. To pick up on where we left off with Amanda, I'd love to hear from you and from where you sit and with the depth of experience that you have on this issue and with IFPMA. Can you characterize where are we at the moment with respect to the present risks, and how are you seeing it show up?
Yeah, thanks very much. So when we talk about present risks, and we just heard it, bacteria are evolving and therefore resistance is increasing. And therefore, we need to make sure that we have tools to stay ahead of them. And those are, by and large, antibiotics. Now, when you look at the pipeline for antibiotics, it is not very strong. In fact, it was been described as insufficient. It's been described as weak. I would recognize the researchers who are here with us tonight and maybe online as well. There are a number of IFPMA member companies that are continuing to work, continuing to invest, dedicated scientists in developing the next generation of antibiotics to treat the resistant infections that we heard about from Amanda. But there aren't many of them. There are also some small biotech companies, and we'll hear from them as well on the panel. And there's also an important but small group of funders and public-private partnerships that are also contributing or working together in a way to make sure that we do have a pipeline of antibiotics that's coming through. But it's insufficient and recognized by most people to be so.
And when we're talking about that development pipeline, that takes time. And the pipeline is relatively long in terms of the need and the increasing urgency of this issue. And so while we're talking about the present, I know you and colleagues have done some very important modeling and have looked at historically what is the data telling us and how can we project that into the future to understand, and going back to sort of the costs of inaction, what is that trajectory if we do develop and implement incentives and not, to understand how those two paths could potentially unfold?
Yeah, exactly. So we asked a couple of questions. First of all, we looked back to the last high-level meeting here 8 years ago in 2016, and we looked at all the antibiotics that were in the pipeline then and how they have, what's happened to them till now. And 10 were approved by regulatory authorities around the world, of which 2 were considered to be innovative antibiotics by the WHO criteria. So the question is that good or bad as a historical view? And that's one question to be discussed. What we then did, and this is the report you have on your desk, is to map it forward and say, over the next 10 years, what do we expect to happen in the pipeline? And as you say, Alison, we considered that under two different scenarios. The first scenario is we just keep going as we are. The declaration and the other meetings that are taking place this year don't result in any meaningful change in terms of the economics of investing into R&D. And therefore, what you expect to see is that the pipeline continues its current trajectory and it's a gradual decline. And so we predict that, and this is working with an expert data analytics group called Airfinity, we predict that only 6 treatments will be approved by 2033 without any changes. Now that is not many. And by that point, the pipeline will be a lot slimmer than today. On the other hand, the second scenario we did was to say if incentives are introduced by governments around the world, maybe as a result of the meeting in September, maybe as a result of the other important meetings going on this year with the G7, the G20, the Kingdom of Saudi Arabia is holding an important meeting in November. As a result of all of that, you could imagine a positive scenario, and that is that other governments will introduce incentives. And so what happens then? So that's the second projection that we did, which you can see on page 7, if you want. And what that shows is that this can be turned around, right? Now, it's not instant. As we know, developing drugs takes time and dedication and patience, as well as investment. But our modeling shows that with incentives being introduced, you would start to see that turnaround happening relatively quickly, and by 2033, you'd see a very meaningful difference.
I encourage you all to dig into that report. It's hot off the presses. And for those of you online as well, you should be able to find a link on the bottom of your screen as well to that. So I do welcome all of you to dive into the data and the details, because the modeling is really impressive and important and is telling a story. And when you're talking about the conversations that have been had, the meetings at the G7 and elsewhere, what are some of the key sticking points and the barriers to the implementation of incentives? What hurdles do we need to get over?
It's a great question, because as we already heard, actually the UK has done it. So it's shown a novel mechanism. It is the subscription model. We will hear more about it in the next panel. But essentially, it's been you could say, a proof of concept. There are some other discussions underway. There's a pilot that's being proposed in Canada. We're very hopeful, which will be an adapted version of what the UK's done. So to that extent, it's a good question of why is it not happening elsewhere? I think it is as a result of the political challenges that we all recognize. There are many, they're all difficult, and they mostly require governments to make choices over where they're investing. Now, so my hope for the opportunity that we have in September really is that that will help build the political will to encourage the other governments to go ahead and implement it as well.
Do you see any specific catalysts to that happening?
I see about 150 of them, and I hope there's another 300 or so online. Yeah, I mean, that's a serious point. I think many of us here in the room are talking to the governments that need to, that will be part of the declaration. We have a co-facilitator here who will be, helping organize that declaration. And so I think we should all be catalysts. As we just heard from Amanda, infections happen to all of us, and we all hope that they can be treated. When they can't, it gets bad really fast. And so this is a personal thing we should all be worried about for ourselves, our parents, our children, etc. And so I believe we all need to be catalysts.
It's a call to action for sure for all of us, and the clear differentiated roles that everyone has to play. I think that's another opportunity about this convening tonight and also those that are forthcoming. And the meeting tomorrow, which is a multi-stakeholder convening and a hearing, recognizing it takes everyone who are coming from various disciplines and who are able to design the policies, the incentives, finance, and also those who are on the front lines and the workers who are actually seeing how this is playing out every day. So I appreciate your leadership and your partnership in this with us. I think we as Foreign Policy also have a responsibility and role to play in elevating these issues for our audience. We are all learning the impacts and ways that we can continue to communicate with research and fact-based evidence how everyone can get involved and the cost of inaction if we don't. So thank you very much for your partnership.
Next, please welcome to the stage Combating Antibiotic-Resistant Bacteria Biopharmaceutical Accelerators Chief of External Affairs, Damiano Di Felice, Fair Bio CEO and President, Dr. Akila Kosaraju, Merck Vice President, Dr. Janelle Krishnamurthy, and One Health Trust Founder and President, Ramanan Lakshminarayan, for a conversation on private sector innovation to combat AMR.
Great. Thank you, everyone. As you can tell, we're building on these conversations and there's so much expertise to be had. And I'm really excited about this conversation about innovation and access and how to bring the private sector to the table. And so kicking off and picking up on what we were just talking about with James, you know, this development pipeline is so critically important and it is long. And while there is very importantly the AMR Action Fund, which has contributed $1 billion to developing antibiotics in the pipeline by 2030, that's not a cure-all. And that's important, but others need to come to the table. And so I'd love to pick up there, and Janelle, first turn to you. And in your experience and perspective from Merck, you know, what is the AMR Action Fund, what it is, what it isn't, and where can we lean into now regarding developing the incentives that are needed to really bring other capital to the table?
Yes, no, thank you very much for the question, and thank you to Foreign Policy and to IFPMA for hosting this critical discussion that we're having today ahead of tomorrow's very important hearing and meeting, and then in September. You know, we were one of the initial investors in the AMR Action Fund. We felt like it was extremely critical and important that we were at a point in time where there were dwindling of new antibiotics, that even research and development was happening because there wasn't the capital that you were talking about. But this is just a stopgap measure. This is something, whereas Merck, we've been invested in antibiotic resistance and development for both end-to-end, from animals and humans, looking at this as a continuum. So how can we combat infectious diseases from, you know, the beginning to the end? And so, as you're saying, the reason we thought the AMR Action Fund was so important to occur was to give governments, to give multiple stakeholders, because this is such a complex issue. There isn't one solution. We have to look at the push incentives to incentivize the research and development, then the pull incentives to get us over that valley of death, because you want to decouple the sale of really appropriate, accessible antibiotics. And so I think, you know, that is why it's important more than ever that me really think about this in a holistic approach, because the time is ticking. As James said, with this new report, it shows what happens when we don't have those incentives from push to pull.
I'd like to pick up on that push and pull dynamic a bit more and understand the mechanisms and the kinds of incentives that we're talking about, and especially under resource-constrained environments, of course, that we all always operate in. And Damiano, I'd like to turn to you. When you think about those push and pull incentives, how would you characterize them for our audience, and what is effective and what is driving impact?
So thank you, and thank you, IFMA and Foreign Policy, for inviting us. So I think that it's important to mention that the report that you have, which is great, so please read it, is the last of a series of reports that have been published on the topic of push and pull incentives. We've had 10, 15 years of reports coming from independent organizations, from government agencies, from think tanks, and I find it important to mention that there is broad consensus across non-profit, for-profit companies, think tanks on the importance of implementing push and pull incentives as quickly as possible. So I hope that the high-level meeting and the political declaration will not request new reports on the topic. The time to act is now on the topic. The combination of push and pull is a consequence of the need to have private investors on the table. I think that in terms of sustainable development, broadly, we know that we need private investors to actually address some of the most intractable challenges. And the question here is how to make sure that we have private partners to work with. CARB-X is a non-profit public-private partnerships. We receive funding from governments and from private foundations, but we need private sector to participate and to partner with us. And our experience as well is that it's becoming increasingly difficult to have both like partners to work in the stages of development that we focus on, which is the earlier stages of development, but also to get downstream funders after we actually graduate projects from us. The consensus is there. If you see, the Global Leaders Group have published a report specifically on the pipeline and access crisis with recommendations to implement push and pull. The Multi-Stakeholder Partnership Platform, which is another UN process, actually came up with recommendations that also recommended the implementation of push and pull. I find it important to mention that the combination of push and pull is not only about the pipeline and the products. It's also about the people working on these projects. And what we want is a sustainable R&D ecosystem. And the AMR Industry Alliance a few months ago published another very good report that looks at the number of people which are leaving the field of AMR R&D because of like the field are people that have been working at companies which have been successful about bringing a new product to the market, but then this company went bankrupt or they had financial problems. And I think that there were 150 of them in the AMR Industry Alliance report. And after their companies have financial problems, only 10, 12 of them actually remained in the field. So we're losing a lot of expertise. And if you take the assets and move it like from where it is today to maybe in the future, if you don't have the people and the teams behind like these assets, it will be incredibly difficult to actually turn on the pipeline again when we actually need it.
And you raise a really important point that the studies have been done, the evidence is there, and we know what to do. And so I'm going to ask you quickly a question that I asked James, which is, so what are the barriers? If we know this and we have the evidence from your perspective and where you sit and having worked in public-private partnerships, what are some of those key barriers?
I think two barriers are related to the fact that the valuation and the reimbursement of new antibiotics is done at the national level. And this creates a global coordination problem. And this is why we're here in New York, and this is why the topic is addressed in the G7, in the G20, because we need multiple countries to come together. And there is, I think, a strong incentive for countries to free ride on the incentives that other countries can put in place. So there is an element on the fact of the importance of global coordination. There is another element related to the electoral cycle of politicians. If you're the Minister of Health today, what is the incentive that you have to put money aside to actually drug a new antibiotic that may come to the market in 10 years from now, 15 years from now? So this is why, as Jane said, we all need to be catalysts to make sure that we convince these politicians to be long-term thinkers instead of just thinking about like what happens in the 2-3 years coming after they may do another job. I think a third challenge is the importance of connecting innovation and access, and I'm sure that others will speak about it like in the panel, but it's important that any push and pull incentive that we have in place will have strong conditionalities related to stewardship and access. And Amanda spoke a little bit about the importance of addressing the problem in a holistic way. We at CARB-X, we have clear conditions on the grants that we provide related to stewardship and access. We know that other organizations like the MR Industry, the MR Action Fund and GARP and others also obviously work with this idea in mind, but also pull incentives should have strong conditionality related to stewardship and access.
You raise a number of really important points, and you were hinting about differentiated roles, responsibilities of varying countries around the world and capacity to invest as well, and as well as advanced different policies. Ramadan, I'd like to bring you in here. How are you thinking about this and how this issue is manifesting around the world and the work you're doing? And when we're thinking about innovation and access being two sides of the same coin, when we spoke earlier, you were talking about the need to drive down costs. And so I'd like to pick up there with you and how you're thinking about these challenges, but also some of the opportunities that you see as it relates to AMR and addressing it in different parts of the world.
Thank you. Thanks for that question. And I think one thing you'll find in agreement across this panel and everyone else is that we do need new antibiotics. We need more than new antibiotics. We need new modalities, even bacteriophages. We need, if we're still dealing with bacterial infections using antibiotics in 50 and 100 years from now, we've done something terribly wrong. So we need to look at these new frontiers. It could be vaccines as well. That said, we've got to remember a few things. Something like 60 or 70% of the antibiotics that are developed don't make it beyond 10 countries in terms of product registration. They never hit the geographies where patients are in need. So development does not necessarily mean that patients in need actually get access to them. That's not just a nice to have problem, it's also a revenue problem for the companies because Merck might be able to get it out to other countries. A small biotech company will not be able to because they don't have the wherewithal to go and register in multiple geographies. So this is a serious challenge. The second is the cost. Even in the United States, if you look at the average cost of drugs that have come out in the last 2 decades, the average cost is somewhere between $2,000 and $15,000. Now, how many of you is ready to have an antibiotic course for 5 days that costs that much money? Have you ever thought of having an antibiotic course that costs $10,000? It's insane, isn't it? But that's the world we're really going into because of drug resistance. So innovation is very important, but we have to do innovation in a way that puts access at the beginning and not as a problem to be solved after we have the new drug. Now, how do we do this? What CARB-X does is one particularly good idea, which is you provide non-dilutive financing to companies and you say, I'm not going to take, away from the returns and investors, but I'm going to, put some money into you to help you take a risk that you might not be able to take on your own. What GARP, which is another organization that's complementary to CARB-X, whose board I happen to chair, and which is set up by WHO, has been successful at actually the clinical stage in bringing drugs to market, not on its own, but helping private companies bring drugs to market. At the end of the day, the private sector is still critical as being the central part of where innovation will happen. But I think we're entering an era when the old model of antibiotic development, which is entirely done by the private sector on its own steam, is over. I think that's what you're hearing. I mean, if it wasn't, honestly. And in today's world, it's going to depend on money that's provided in this push kind of a way. It might be money that's provided in terms of providing access to clinical trials networks for things like CMC, which is basically another way of saying quality, which is accessible to a lot of small biotech companies. 80% of antibiotic development happens not in large pharma, but in small pharma. They don't have the wherewithal to do all of this stuff. And unless we're able to make the cost of drug development much cheaper than it is right now, we're all going to collectively fail because you cannot justify bringing a drug to market that costs $1-2 billion, which is the typical cost of bringing a drug to market. Because if you bring a drug to market at $1.5-2 billion, you're going to need a $6 billion incentive to have brought that drug to market at all. So these mechanisms use approaches that we use for malaria, for instance, which always relied on, say, Walter Reed working with private companies like MSD, like Pfizer, like GSK, and then driving down the cost of bringing drugs to market. And if we do this in the way that GARD-P is doing, or say DNDi is doing, where you're saying, I'm going to spend $150 million to bring a drug to market, and then we have some chance that that company will survive, make some money, and then the drug will get out everywhere. The last thing I'll point out is that providing access is not a nice to have. Providing access means enabling companies to reach the places where the patients are. If you're just going to write off India and South Africa and Nigeria and Brazil, you're missing out on where the large markets are. So if development assistance, like with the Global Fund, are able to provide monies to provide new developing countries, that provides an opportunity for private pharma to also then access these places. It doesn't have to be a push or pull incentive. You're doing the right thing. You're getting to people who need the drug at the price point that they can access, but then you're enabled to staying in business and going ahead anyway.
Thank you for putting some numbers to that and to give us a sense of that scale and the degree to which those costs really need to be driven down. And so picking up on that, and Akhila, over to you, when you're thinking about what Ramanan just said, and also the work you're doing with artificial intelligence and driving innovation, how are you thinking about those cost issues and ways in which potentially technology can help drive down costs while accelerating the innovation that is needed throughout the pipeline?
Well, first of all, thanks for the great question. It's that small biotech is being represented, and truly almost every speaker has mentioned the innovation bottleneck and how much small biotech really typically fills that critical role. At my company, Fair Bio, we are using artificial intelligence in a number of ways, and I just want to highlight a few of them that are related to cost. So, obviously there's a lot of energy and potentially a lot of hype right now around AI globally. And we've actually been using this technology for practically the last decade in partnership with a lab at MIT, Jim Collins' lab. We've found that it's particularly useful for antibiotics. And that's really for three reasons. One is that you can train the AI model to really identify novel chemical spaces. And so given that that's actually the fundamental issue with our current armamentarium of antibiotics, it's really getting to the core issue. So you can train for example, we train models on find an antibiotic find a molecule that looks like it has antibiotic properties, but it's sufficiently dissimilar from current structures. So that's incredibly powerful. The second reason is that with AI, you can really create this rapid feedback loop specific to antibiotics where you can test your hypothesis in a petri dish. Very different from, for example, cancer immunotherapeutics or neurodegenerative disease, where really the models need to be more advanced and ultimately get into humans as quickly as possible. And the third is going to this issue of cost. And I would say cost and scale, all very interrelated. We can now screen 20 million compounds a day, and that's really on a bad day, compared to 20,000 compounds using fairly advanced traditional methods. So there's an order of magnitude and a possibility that we couldn't have even dreamed of before. So that gets both into innovation, but also cost. So just to give you a preliminary figure, we've been at this for a couple years from an operational perspective, so the denominator is fairly low, but we're finding a 20% reduction in cost. But more so, the big reason why drugs, cost about $1 billion is all the sunk costs of all the failures along the way. And we're actually finding that one of the biggest advantages of our, focus on training models and really having now generative AI actually design new compounds is we're having to take fewer shots on goal. So we're now moving into a lead program with just about a half dozen programs that, we decide not to move forward with. We think that ratio is actually extraordinarily high. So I think that's what is worthwhile to watch with AI and with some of these technologies, is that the level of precision, the number of shots on goal, the cost of computation compared to the cost of massive robotic capabilities and the lab space you need with traditional methods is incomparable. But the last thing I want to say is, as you hear about all of these computational capabilities in the life sciences broadly and specifically in infectious disease, it's always paired with human expertise. The two are absolutely married from beginning to end. So we have microbiologists do the fundamental training data sets in Petri dishes, and then ultimately with the molecules that are coming out of the AI model, again, you take chemists and microbiologists who look at these compounds and ensure that they pass a reasonable test and quickly can prioritize amongst innumerable compounds that are coming out of a computational platform. So our goal is not in any way to replace human expertise, and I think going back to the the Industry Alliance report, which we found incredibly motivating, we are actually trying to pull new talent into this space, and we found that it's incredibly powerful to show young talent that there is an avenue to pursue in AMR and infectious disease broadly that's exciting, that will pull different types of funders to the table, that can further your career by enabling you to hone in on another skill set on the tech side. So we really hope to expand the tent, and we found that that's been really successful. And I think one of the proudest things that we as a team feel is that it's really interdisciplinary, it's relatively young, and we have the capacity to really grow that and also enable scientists around the world to just log on to a portal where they can look at AIs. And that's really our goal in the end, is to make this as, in terms of access on the front end, to make sure that there's a lot of access to researchers around the world to be inspired to do this work.
I think
Sorry, that was a mouthful, much more than you were looking for.
No, it's great. And I think you raise a number of great points, including accessibility in terms of research and collaboration across countries to really tap into the knowledge base that exists and to be able to work together and hopefully disseminate that knowledge more rapidly around the world. And it's exciting to start thinking about how that technology also can be applied to the different issues and metrics that we discussed. And there are the challenges, and we focused on them, but I'd love to tap each of your brains in terms of the opportunities and models that you see that are working. When we think about innovation, there is hard science and technology and the work you're doing in the lab. There's also innovation as far as policy is concerned, the types of partnerships that are being crafted, and that Damiano that you referenced and others. So if we can lean in there for a moment and really distill what's working, what can be learned from here in the room and those are joining us online, what would you point to? And where would you welcome others to come talk to you about and learn from the work that you're doing? Janelle, I'm going to turn to you, Damiano, and then Ramanan.
I think, as my fellow panelists have said, a lot of the solutions depends on the country, the government, and what they see is a viable option. And to your point earlier, right now with all the geopolitical volatility that's occurring, it's really hard to even keep health as a priority. I think many of us know after COVID, people are like, let's move on and look at other issues, and we have big deficits. So it even makes it more of a challenge for all of us to ensure this silent killer of AMR is being recognized. And some of the programs that we're seeing, the UK, Japan, really looking at subscription models. That has been a key where, as you were saying, it's important to have access, but the right access and the right incentive with all the guardrails around that incentive. Also, the EU and the pharma legislation that they have been working through over the years is looking at transferable exclusivity vouchers. And again, very important with that to have the right guardrails on there. But those are two models that has been getting attraction around the world. And in the US, I think Amanda spoke of the Pasteur Act, which is also a modified subscription model that the US is looking at.
Great, thank you. lots more to dig into regarding the subscription model. But Damiano, from your perspective, what is working and what would you point to in terms of partnerships?
I would say that we are lucky. You know, AMR is a very big problem. It's an infrastructure problem for our society. This is why we bring it to New York and we have a high-level meeting about it. And on the innovation and access crisis, we have a solution in front of us that has been proven to work. I know we have public-private partnership pushing new projects. At CARB-X, we have like more than 18 projects that have moved from preclinical to clinical development. At GARP, I know they have a product which has gone through phase 3 clinical trials with positive results. And on the pool incentive side, the UK government is very happy with their subscription model. You have pharmaceutical companies working with the government, participating in the program, and they think they're getting a lot of value because they did a health technology assessment looking at the value of the antibiotic, and they think that they're underpaying for it, for the value to society. So we have a solution in front of us in terms of push and pull. The question is, are we willing to implement it with the phase of actually the crisis that we're facing? And speaking a little bit like what Ramanan was saying, I also find it important to bring a little bit of bad news that innovation and access are not that cheap. You have to invest in these things, and they do cost money. There have been other reports showing the fact that there is a big return on investments, both on the push side and on the pull side. The estimate that we're working at the moment is the fact that you as a pull incentive, you should pay roughly around like $300 million a year across different G7 countries. And this is big return of investments across all these countries. But this is only pays for success. This is also another important element that we have not spoken about pull incentive. This is money that only pays for success. If you craft the pull incentive in the right way, you only pay for the antibiotics that you want.
Ramanan, how would you pick up on that?
I think let's get very concrete. If you had, just for argument's sake, an antibiotic that costs $20 million, you don't need push or pull incentives. You just, there's enough people, enough patients to pay for it, even if it's India, even if it's Mexico. The whole reason for this is these are expensive things to invest in. So I think the successes today have come from leveraging developing country institutions, scientific institutions that provide, support. They might not do it for a private company, but they do it for public-private partnerships. We have a long history of doing this, going back to neglected tropical diseases. That's why public-private partnerships are not optional. This is the only approach going forward for AMR. There is simply no other way. So that's one. The second is public funding is important. Why? Because something like 50 to 60% of the cost of drug development is the cost of capital, because you have to go and, you've got to take money from someone in the market and you've got to pay them 25% a year or something like this. But once countries make that investment from a public health perspective, then your cost of drug development goes down significantly. A third is when you're able to leverage a lot of cross, project expertise. Both CARB-X and GARP do this really quite well, because then we provide platforms for CMC, platforms for clinical trials, enable companies, small companies to share things which otherwise they would have had to build on their own. And in some instances, antitrust laws might prevent them from working with each other. What people might not remember, or nobody here will remember this, but when penicillin was developed, Congress actually dropped antitrust provisions which allowed 5 companies in New Jersey to work together because the development of penicillin was deemed important for the US war effort. That was the kind of effort that brought penicillin. We're not doing anything close to that in terms of the urgency of the problem, and I'd argue the problem is as urgent as it was then. And I think there are ways of actually doing that. And I think we really have to focus on cost of drug development. If we don't do that, we're going to end up with expensive antibiotics that can't be sold anywhere. One company, which panelists know, 2 years ago, they made $1 million in their first year of business after having sunk $200 million into drug development. I don't know, but you don't have to be a genius to say that if you make $1 million a year, if you spend $200 million, you're going to go bankrupt very fast, which is what happened to that company. And the reason is they had to price that product to be so high that nobody was able to afford that product. So let's focus on cost of drug development.
I love how you characterized your opening statement there about let's get concrete. So we are out of time, but I do want to ask each of you in this speed round before we go, and not to run too much over, but yeah, let's get concrete. Tomorrow are the multi-stakeholder hearings, and from each of your perspectives in the roles that you have and where you sit and the experience that you bring to the table, what needs to be focused on? And when we're getting concrete, what do you want to see happen tomorrow? Akila, I'll start with you, Damiano, and then we'll go down the line.
I mean, for us, it's critical to have pull incentives. Something to look forward to in the future, something we can tell our funders is a way that this will all actually ultimately get paid for, hopefully with some kind of return. I think the push incentives, enhancing those is always helpful. And now the pull incentives need to really be exponentiated and collectivized and really rigorously funded.
Damiano, then Janelle, and Ramana.
I hope that the high-level meeting and the political declaration will call for countries to mobilize financial resources to ensure sustainable access to effective antibiotics, meaning new and old antibiotics, and putting access at the center, recognizing that innovation is needed to have new antibiotics as well.
Janelle?
I think I'm hoping and advocating, and I think it's all of our responsibility, that we're going to really have bold declarations tomorrow and in September that comes out. So there's sustainable discussion after September. So a One Health panel on evidence and asking for action on combating antibiotics, which was called in 2016 to be formed. And this can be a sustainable body that can be bringing member states together, looking at the evidence, looking at gaps, coming up with targets, and ensuring that we are making progress going forward.
Well, because this is the UN and not just the US, which my answer would have been different. If it's the UN, innovation without providing access to the millions of people in low and middle income countries is just a waste of time. It's not worthy of a discussion of the UN. So unless we figure out access, the innovation discussion is dead. And I think that's what you'll hear from many LMICs. We might do things for ourselves in the US, but that's not the same metric that many LMICs will use. So we really need to focus on access.
Well put. Thanks to all of you for being here and for the work that you're doing. We appreciate it. Thank you.
Thank you very much.
Thank you.
Please now welcome to the stage the United Kingdom's Head of Global Health Security, Niall Fry,
Thanks so much.
the Swedish Ambassador on Antimicrobial Resistance, Dr. Malin Grappa, and the World Health Organization representative at the United Nations, Stuart Simonson, for a conversation with FP's Andrew Solinger on innovative approaches governments and intergovernmental organizations are taking to rise to the challenge of AMR.
Welcome. Thank you.
Well-planned follow-up after hearing all about the private sector initiatives, public-private partnerships, and certainly what some of the wishes were for outcomes from tomorrow, governance and follow-through. And really happy to have such esteemed panelists and representations from government and multilateral institutions to talk a bit about how we can put those into practice, and want to dive right in. So let's go for it. Stuart, it would be great to start with you. I was quoting WHO data earlier when we were kicking off.
Good.
So I'd like to come back to the WHO and talk a little bit about the measure that the WHO adopted in 2015 at the World Health Assembly, calling for national action plans to be instituted. And 4 years later, the Director General talked about the need to push implementation of those action plans. And to throw a data point at you, these exist. There's 180 of them, but only 11% are financed right now, or funded. So tell us a little bit about the progress that has been made, and what are the barriers here?
Well, first, thank you very much, and thanks for including me in this event. I think we have to accept that is some progress, right? Actually having national action plans. And so there is, I think, there is reason for optimism here, but it is ultimately, it's about funding, right? And if only 11% of the national action plans are funded, what are the odds that the national action plan is really going to result in anything? Look, for example, at training of healthcare workers. They have only maybe 10% of these member states actually have a standardized, developed program for training healthcare workers. Without training healthcare workers, you're not going to be able to address some of the basic issues that are causing antimicrobial resistance: infection prevention and control, water sanitation and hygiene, and so forth. And so I think it is about funding, and it's also about governance, right? And there's a good story there, too, I'll tell you. The quadripartite is strong. It is, in fact, I would tell you, in my experience, which goes back to 2003 with H5, never then was there talk of, consulting with WHO and FAO and OIE and so forth. It was always just WHO. But now it is a real partnership. And that partnership, I think, is the solution. It is the way to drive this forward, to give real meaning to One Health. One Health not as a slogan, but as an actual practice, as an actual institution.
If we could come back to financing for a minute, what are some of the constructs here that are blocking financing? Is it political? Is it financial incentives? What's your take on that?
I think, while we have had success multilaterally in working between health and ag and other sectors, I don't think that is I don't think there has been as much progress in member states. And I think that's a big part of it, right, is working together and identifying the problem. And where the problem is recognized and the significance of it, funding follows. I don't really think that AMR is particularly well understood, right? 3 initials that people are worried about. But really, what does AMR mean? You all know. But if you go out into outside of New York or outside of places that are interested in this, there's not a lot of understanding. In fact, everyone in this room has been impacted by antimicrobial resistance. Maybe a distant family member, but it is serious and it is every day. And I think if people understood that more, the funding would follow.
I would love to just to keep with you for a second here and come back to the quadripartite and the importance of that. The FAO, UNEP, World Organization for Animal Health, have taken a lot of strides on this. What does this mean to AMR? Maybe you could help educate us on that. Why is it important to have those groups working together?
Because decisions made related to animal health affect human health. Decisions made in human health affect animal health, plant health, and so forth. And it's more than just treating a particular disorder. Doing something in human health or animal health has consequences, right? And it is, antimicrobials is essentially a code-breaking exercise by nature. The more they're used or overused, resistance follows. And you have to both innovate, but also exercise real stewardship. And I think focus on equity in terms of access to the antimicrobials, but also equity for diagnostics and so forth. It all comes back ultimately, my own view, to, at least for human health, to primary health care, universal health coverage, right? That's part of it. But I also think it is about the recognition of the problem and what it means personally.
Got it. Malin, would love to bring you into the conversation, if that's okay. I would love to hear a little bit, let's get into some of the country approaches, if we would. A little bit about Sweden's strategy, your intersectional strategy based on Well Health, One Health. It combines human, veterinary, environmental care. And you have a low use of antibiotics in Sweden, is that right? Maybe you could tell us a little bit about that and how that's created a favorable situation when it comes to AMR in Sweden.
Yeah, thank you for this question. And of course, I need to start with just saying that we started very long time ago with this work. So yes, we do have a favorable situation, but our first national action plan which was already then cross-sectoral, and that was published in the year 2000. And some of the goals in there are still not entirely achieved, so it also requires some patience. But yes, we do have a true One Health and multi-sectoral approach to AMR, and that, I mean, it requires patience, absolutely. But we invested a lot of efforts and energy into making this intersectoral coordination group that we have a really good collaborating group. And this group is really, it's not only human health, animal health, and environment, but it includes trade, education, research, development cooperation, for example. So it's a true multi-sectoral collaboration built on trust. I think that is something that we achieved along the way, and incredibly important, of course. When it comes to the use of antibiotics, again, we started early. Our national stewardship program started in 1995. And it's the basis for this is the data. So we look at the prescription data, we develop treatment guidelines based on resistance data, and then we have a peer-to-peer approach looking at prescriptions compared to guidelines and adherence, and have these peer-to-peer discussions around this across professional groups, but also with an element of benchmarking. We do publish this data both monthly, quarterly, and annually. So there's also transparency around the entire surveillance. So the benchmarking between the regions, we have a decentralized health system in Sweden. We compare the regions, and there are...
competitive?
Yeah, it is, of course. If you publish the prescription for each region openly, that brings in the benchmarking. We also have national targets on prescribing, so we also can measure their progress towards these targets. So it's proven really useful and helpful for us. Of course, this is also a bit context specific, I believe, because in Sweden, we have this kind of broad consensus culture. We have not so hierarchical systems. We can really bring in the nurses, the pharmacists, and the infection specialists in the same group and have these discussions around these topics. And it's a bottom-up approach very much. Then, of course, it's met by the national strategy and the governance that we need from top level, of course, as well.
That's great. And maybe you could just tell us a little bit about the early start it sounds like Sweden got, back in 2000 and even 1995. What's some of the history there? What do you attribute that to?
Well, I would really like to start even earlier, because in 1986, we banned the use of antibiotics in animals for growth promotion. And that was based both on what we could see, that we had an increase in resistance, but it was also, we didn't have all the evidence there for this decision to be taken, but it was taken with the precautionary principle. And it was very much in dialogue with the private sector and the food producers. So I think that was really the starting point. But in 1995, this national stewardship program, that also started from the physicians themselves seeing that we have problems here. We cannot treat our patients as we expected. So it was really a grassroots movement from the beginning. And then after a while, it also gathered the necessary political will from top level. And that's how we continued.
Fantastic. Would love to come back to you and hear a little bit more about a broader European strategy, if you could speak to that also. But I'd love to bring Johan to the conversation And we've talked a lot about this famed prescription program that the UK has employed, the Netflix strategy. And we promised that we would dig into that a little bit. It's been, how long now? A couple of years?
2 years.
2 years. Would love to hear, well, first of all, and if you could brief us, explain for us here and in TV land a little bit about what that means and what your experience has been.
Yeah, so other streaming service metaphors are available, but Netflix subscription model is how it's often been referred to. I think the previous panelists covered this a bit, but it's essentially the business of trying to de-link the profit element for pharmaceutical companies from the volume required to sell. So obviously with antimicrobial resistance, you're not looking for a situation where the return on investment that a pharmaceutical company can make is tied to how many antibiotics a GP practice, primary care, can push out the door. So in the UK, I think it's back in 2019, we started with a couple of new antibiotics. This subscription model, essentially each year the UK provides a certain amount of money to these pharmaceutical companies. They know they're going to get this set amount, and in return we have access to the antimicrobials we need, but only use those, of course, that use them in the cases that we think they're most necessary. So very much kind of following the WHO AWARE model, keeping them on the back shelf for use when other existing antibiotics fail. So yeah, we passed it through our kind of National Institute for Clinical Excellence. It's the part of the UK government that assesses healthcare interventions and decides if they're value for money, having impact. This one was an interesting study because we were not just looking at those who'd received these particular antimicrobial drugs, but also trying to make an economic analysis of those who did not receive them and received some of the more standard pre-existing antibiotics. But we think it's been successful. We're keen to try and roll it out to other drugs that might come out on the market. But I think, as previous panelists were saying, I think the UK, has 3% of the antimicrobial drug market. To really create the added pull incentive, we need to be able to implement that subscription model in a variety of different countries to build up the incentive.
Yeah, and you were just telling me you were about to or have just published a new report as well on
yes.
On
success. If I was the author, I'd be here with my copies to sign. But the UK has also, in the build-up to the high-level meeting, we've published our updated National Action Plan for the UK. Lots of good material in there, recommitting ourselves to our top aim as a UK government is to contain and control antimicrobial resistance by 2040. That's the target we work to, and every 5 years we publish an updated National Action Plan that covers the health sector, agriculture, food production, environmental, that sets out the steps we're going to take to get towards that. So yeah, available on the UK government's website. It's inspired by lots of lessons learned from other countries, such as Sweden, but other countries around the world as well.
Great. Yeah. What's changed since you last updated the plan?
We've got a lot of, so on the innovation side, we've got some quite exciting stuff coming through. I think one of the things we're particularly gripped with is the need for more research on the social and behavioural side of antimicrobial resistance. So I think in the UK, we always naturally thought AMR, R&D, well, that's the discovery of new antimicrobial drugs, and that's absolutely vital, and we need that. But we're starting to hone in a little bit more on some of the behavioural drivers of antimicrobial resistance. So, this classic scene, which we've all had before, where you go into the GP practice, as it is in UK, your primary care physician with a problem, and your mind is already turning to what's the antibiotic going to be that's going to get me out of this? And the GP, the physician, knows that you're probably going to ask this question, and it's all these interesting studies we can do about how you help both professional and patient through that sometimes awkward discussion. So we're looking forward to setting up what we think will be called the Fleming Centre in London in 2028, which is going to do a lot more of this behavioural and social kind of research analysis, and it's also going to kind of try and do the business to bring in policymakers from lots of different parts of government together as well. So colleagues have spoken about how responsibility for AMR is spread across lots of different government departments. We have that in the UK, of course. We have to try and coordinate across our Department for Development, our Ministry of Health, our Ministry for Agriculture. The new centre is going to try and be a bit of a prototype of bringing policymakers from a range of different backgrounds together in the same place, trying to kind of tackle some of the wicked issues of antimicrobial resistance, both the science, the behavioural aspects, the social.
Role in some of the rollouts in the EU, different national plans that you've seen and that Sweden has helped with. Would be great to get some insights from you on.
Yeah, I mean, the EU just quite recently adopted a new council recommendation. That is not a legally binding agreement, but it's negotiated among the 27 member states, and that is not always as easy, even though it's not 193. And in this council recommendation, this was during the Swedish presidency of the EU Council last year, we had specific targets on reduction of use and reduction of resistance. And it was surprisingly easy, I must say, to negotiate and agree on these targets. So I think that's quite reassuring. We talk a lot now about the political declaration, and we still don't know really how we will end up with that. But it was really reassuring to see a new higher ambition and stronger commitments from these member states. I was really happy to see that. Another negotiation that is still ongoing is the huge package of pharma legislation. So that is a different story. It does contain several elements on AMR. We haven't really reached to them yet. This will take years probably. But it does include, for example, as I guess you might have discussed already today, voucher as a type of pull incentive with data protection extension. But in this council recommendation, we actually also already agreed on piloting a similar model to the prescription model. UK has one. Sweden has also piloted one already with a revenue guarantee for access to antibiotics. The Swedish model being a small country with not so much impact on global incentives, we did it for access to existing or recently approved antibiotics. But the same model is now being tested at EU level, and that was agreed last year. So this is starting now. It's again a test. And we will have to wait for the negotiations of the pharma legislation, of course, also to see where we end up on EU level when it comes to incentives and access.
Well, it's great to hear that there's some good EU unanimity on how to move forward, more than we sometimes see with 193 member bodies. But speaking of which, it would be great, Stuart, to start out and chat a little bit about what we hope to get out of these high-level meetings. We keep referring to tomorrow's meeting and the meetings in September. What kind of outcomes would you like to see from these meetings in the high-level meeting we'll have in September?
We want to see targets, right? Commitments made. We want to see an independent science panel created, right, within the context of the quadripartite. And I think anything that is in the political declaration that enables and empowers the quadripartite will be welcome and a sign of real progress.
And that's actually a question that we had submitted early from Wellcome Trust's Jeremy Knox, which was, given the breadth of issues where action is required, is there value to moving towards a target-based approach with regular progress monitoring and follow-up, as we've seen in other areas of health and climate change and the like? And how can, how would we move towards that approach? What kind of declaration would you like to see? Malin, you just talked about the value in Sweden's competitive tracking. Would be interested to go to you on this and understand a little bit more about your thinking on the value of targets. You just mentioned that for the EU as well.
I mean, targets are, of course, amazing to drive engagement and progress, absolutely. When it comes to AMR, it's also incredibly difficult to find that perfect 1.5 degrees targets, because it's more complex than that. So I hope we will be able to agree on something. My take would also be, and this I think would be even more useful for actual progress, that is to have countries committing to setting national targets, because then they could be more adapted to context, and I think that could also motivate, or it has to motivate also more of priority setting, and again the funding, allocation of funds for implementing national action plans. So that's something that I really want to see, and then we could join under some more overarching goal or a vision, like effective access to effective antibiotics, for example. So that is also a way to move forward on this. But I really look forward to seeing the zero draft and hopefully the targets that we will have in there, and hear the reactions from member states.
We'll talk a little bit about zero draft. We'll move in a minute. How about over to you, Neil? Take us home a little bit on what you'd like to see come out of this, but also, what are the next steps after the UN high-level meeting? What comes after that?
Yeah, I think that's a good place to start, because I think the UK's kind of placing ourselves as ambitious realists is how we're approaching the high-level meeting. We know that we're not going to solve everything in the high-level meeting. It is a stepping stone towards action over the next couple of years. We've got the Saudi ministerial coming up in the autumn and many events thereafter. But that said, we are ambitious for the political declaration itself. It does have to be a stepping stone, and we want to see it be a stepping stone for everyone, not just a selection of countries. So yes, we want to see an independent science panel. We want to see targets. But we want the world to feel like they own those targets. Great if we can get some things in the declaration by September, but we hope the independent science panel will take all 196 member states through the process of developing targets which meet the needs of all member states. So we see that as a priority. We want to see the quadripartite strengthened. Stu's spoken about what good work it's doing, but there's always more to do, and making sure the whole of the UN family is engaged in the effort. Malin has spoken to the need for member states to be able to hold each other to account, to share best practice. We would like to see a kind of framework potentially established around that. But I think first and foremost, where the UK is wanting to see the declaration deliver on access. And I think we've seen in other parts of the global health debate over the last couple of years, don't need to name them all here in the 1 minute that's counting down on that clock, how vital access is and how complex it can become in international negotiations. So it's often a very difficult thing to explain to a minister from my part of the world who's got very used to the idea of how we must not prescribe too many antibiotics. That's the answer to AMR, to begin the process of education that's required to explain and take a domestic-facing minister on the journey of understanding that whilst we're fortunate to have an overprescription problem that we need to get on top of, vast parts of the world do not even have access to the basic antimicrobials we take for granted. It's an interesting juxtaposition for an uninformed newcomer to grip. So we want to see it deliver on access, and I think the only way we're going to solve some of that access problem is really trying to build on some of the reforms that we're seeing elsewhere in the international system. So the big efforts through Bridgetown to try and increase as much financing as we can possibly get our hands on, to stretch the balance sheets of some of the big multilateral development banks and make the process by which low and middle income countries access that funding an awful lot more simpler than what it is at the moment.
Yes, that's a good point. There is some templating we're doing with in the climate and the environment that can be applied here as well. Well, I've heard a bunch of different great ideas on targeting, all under the rubric of governance, on targeting, on the whatever subscription streaming service you would like to use, streaming starting early, using data, comparative data, making it competitive, and the importance of the quadripartite to keep that going.
I think there's also, in addition to the process that leads up to the political declaration and the high-level meeting, we also have to take advantage of this opportunity to educate and advocate about AMR. as I said, I know that a lot of people in this room understand it, but it is not widely understood. If it were widely understood, if the threat, the individual threat was known, money would follow. The fact is, I think people think that it is something that happens somewhere else, but it happens in every hospital. And in fact, it happens in the best funded hospitals in the world. They can't even control these things. So it means something very personal to someone who has cancer or a genetic disorder. They're more likely to die of that than they are of the underlying condition, of an infection.
Yeah. As you've mentioned, it's impacted everyone in this room in some
Right,
some
but
shape,
it's
manner, or
not,
form.
because it
you're
kills one at a time,
Yeah.
it's not particularly, I think, well understood.
Yeah, understood. Well, it's wonderful that we have so many smart people focused on this in lots of different organizations and countries. Thank you so much for spending the time and sharing that with us. I really appreciate it.
Thank you.
Neil, Malin, Stuart, thank you so much.
Thank you very much.
Thanks so much. Please.
And now, please welcome to the stage Ambassador Francois Jackman, Permanent Representative of Barbados to the United Nations, for his final thoughts on opportunities for AMR resilience.
Francois, welcome.
Thank you very
much. Please
much.
join us. So it's you and me and between drinks. So we'll move right into this.
We'll be brisk then.
No, we'll be very focused. We were chatting earlier and talking about the zero draft. Everyone's asking about the zero draft, and your response was, "What zero draft? What are you talking about? I'm not sure I understand."
I've got it here, short and concise.
We'll be handing out copies to everyone. So tomorrow there will be the big meeting, the multi-stakeholder meeting on AMR. It will obviously be key to ongoing preparations for the high-level meeting hosted by Malta and Barbados this fall. Today we've discussed R&D, innovation, access, and governance just now. Would love to, in the short period of time we have, talk about the importance of the role of each, and how, if we can kind of bring it home a little bit, how private and public sectors can collaborate to solve for those.
Well, thank you very much for the invitation, and thanks also to IFPMA for allowing me to come by and talk a little bit about this, given that I am not, unlike all of your previous guests, an expert on AMR. I'm just a grubby diplomat trying to help the 193 members of the UN find some consensus around this complicated issue. And I think you've heard what all of the issues are this evening and tomorrow, and I'm really looking forward to this. We're going to hear from some of you here and from others as well about what the stakeholders in this process have to say about this. What are their priorities? I'm encouraged that around the big issues that you've already be emerging some sort of broad consensus about what needs to be in this political declaration, that we need to be able to say something important about governance and what we do after this political declaration is arrived at. We need to be able to say something to developing countries who are in many ways in a very different place than rich countries are. We need to be able to say something specifically to them about how we will help them overcome the AMR-related challenges that they face. I spent this morning with a youth group on AMR. We need to be able to talk to the most vulnerable groups within the AMR community. We've heard about it, a person suffering from cancer and other diseases. Younger people, other vulnerable groups need to be brought in. So tomorrow's event really, I think, is going to be a great moment, a great punctuation point. And then the co-facilitators, my colleague from Malta and I, our teams and the excellent colleagues that we have in the WHO quadripartite group are going to try and put all of this together into a clear, short, action-oriented, science-based, commitment-forward legible document between now and September, with 193 countries agreeing to it.
Simple task that you've set yourself. So we look forward to seeing that document, as I know many in the room do, and we know you'll do a fantastic, concise job with it. Beyond, one of the things that I've heard repeatedly, and not sure a perfect answer to, is financing, predictable financing. And I'm not going to put you on the hook to come up to how to address that, but what are the most, that's the key one. If you were to move beyond financing, what is the most, what are the most impactful and practical steps we can take right now to address this huge threat for humankind, animal kind, and the environment?
Well, I think you've heard a lot of answers on that today, this evening. There's clearly a market problem that needs to be fixed through various tools, which I think are quite well known. I have to say, and I in this context, as co-facilitator, I'm just the custodian of this process for 193 countries. But I would say for a large number of countries, including my own, kind of the entry point into addressing AMR, and I think Neil from the UK mentioned it and others did as well, are these national action plans. Malin mentioned Sweden's as well. The national action plan is kind of the building block for all countries and how to address AMR. And there's a striking statistic, which is there's a large number, I think it's only 27% of these national action plans are properly funded. So you are immediately confronted with a problem, which is even though you can kind of identify it, most countries now have a national action plan with the right kind of One Health multi-sectoral approach. You've got that, but you've got many countries are facing the problem of simply funding what is a kind of starting point, an entry point into the problem. So I think that really has to be addressed. So it's not just money, but money is involved, financing is involved, international cooperation is involved. And I think that is, for many countries, the first most obvious point of entry, that this declaration and what we do afterwards in implementing it really has to address head on.
Neil brought up an interesting point and mentioned the Bridgetown Initiative and stretching multilateral development financing to try and meet this need. I was interested to get your take on that. Has that been discussed as a potential solution with the this is something that we're pushing right now in the environment space. Will it work in health and with AMR?
Well, again, in here I'm not speaking as the co-facilitator, but as the permanent representative of Barbados. The answer is yes. The Bridgetown Initiative and initiatives like it make a broad argument, which is you have to sweat or stretch the existing international financial institutions to make them produce more public funds at better terms over longer periods of time. You have to bring in the private sector, and this is obviously particularly relevant in the AMR space, where the private sector is the part of the system that drives innovation. And then you have to ensure that these new instruments, these proceeds, are spread as far as possible to those who need it the most. So certainly Bridgetown and other initiatives like it speak to the need to really change the international financial architecture to address SDG implementation more broadly. Obviously, global health falls under that, as does AMR. But something simple like the World Bank, which is possibly the most important of all the international financial institutions for developing countries. There are funding opportunities and funding windows within the World Bank, as it's been explained to me, to address AMR. But they're not that visible. They're not that well known. The AMR community, the clinicians, the ministers of health who deal with this don't really deal with the World Bank. That goes through the Ministry of Finance. So I think one of the things certainly I would like to see come out of this process is an illumination of where the funds are, where the support is, what the mechanisms are, so that those countries, those sectors that need it, can more easily identify the funds that exist within the system. And then, of course, we need to find more funds more broadly.
Great. And on that point, and we only have a couple of minutes left, so this might be a great opportunity. Big day tomorrow. You've got a lot of the people who really care about this issue in the room right now, standing in the back, very engaged, which is so encouraging to see. What can we all do to help in this initiative and in your role with the Zero Draft to make this a successful effort so that everything that you're just talking about, highlighting what financing is available, pushing on national plans, access, to make that a success and as productive as possible? What can we do to help?
Well, I think the leadership of countries and institutions here and their dialogue with capitals is critical. So we have a group of countries, Mexico, there's the UK, there's the group of friends we've mentioned. The connections they have across the globe to policymakers in different parts of the world, north and south, east and west, because the problems are different. These connections are vital. And I would say to you, who are those who know the most about AMR probably anywhere in the world, come to think of it, is to reach out to your networks in our capitals, across our regions, in our various hemispheres, and make sure, first of all, that there is a suitable level of awareness of the issue itself, a high level of awareness of this process that we're engaged in, and what the potential pitfalls are of not being engaged and the potential benefits of being engaged in this process and in the follow-up afterwards. So I would say I'm the ambassador of Barbados, you guys are the ambassadors of AMR, and really I would encourage you to get out there, spread the word, make sure that the ministries of finance, the ministries of foreign affairs, the ministries of health, who are sending negotiators to these discussions, are aware of what's at stake here. Because sometimes in the kind of wicked problem that this is, it can get lost in the bureaucratic entanglements to these negotiations with strong mandates, well-informed principles back home. I think we will be able to deliver something really useful in September.
That's fantastic. I love that as a closing point. We've talked a lot about the importance of education tonight, and that really brings it home. And also the fact, Ambassador Jackman, that you've anointed us all AMR ambassadors, I enjoy as well. So I thank you very much, Ambassador. Good luck tomorrow. I know we'll do fantastic work. And to all of you for joining us as well and as AMR ambassadors. Thank you so much.
Thank you, Andrew.
Please. Just in closing, before we go, I just wanted to mention a couple of things here. I think I do have some closing thoughts. We have certainly heard a lot of fantastic and enlightening perspectives and shared best practices. I learned a lot. I hope you did too. And I hope you leave with a deeper and more thorough understanding of the role of innovation, sustainable global health ecosystems, importance, access, reaching more people nationwide, and we've heard it over and over again, financing. I want to thank all of our panelists, really did a fantastic job. And I most definitely want to thank our partners at IFPMA for helping us pull together such a fantastic program. I really enjoyed it, and we couldn't have done it without them. And of course, all of you for joining us today. Your participation is important in moving the ball forward here. At FP, we're incredibly focused on global health, as I mentioned earlier at the outset. And I just wanted to mention that this kind of constructive dialogue is what we do very effectively, and we do it all around the world. And we've got a couple of programs coming up that I wanted to mention to you and hope that you're aware of. First of all, if you're attending the World Health Assembly in Geneva at the end of the month, we will be there. We're holding our Global Health Forum there for the first time. Please do join us. You can talk to me about it, or you can talk to my colleague Zach, who's here in the room. He's over in the corner with the tie, waving his hand right now. We're all wearing ties. That wasn't very helpful, with the great beard. Zach actually has really helped drive our health coverage and our focus at FP, and I want to thank him for that. And he also just got a big promotion yesterday, so please thank Zach. He's Vice President of Partnerships at FP. Very importantly, he reminds me to tell you about the Health Forum that we're also hosting at UNGA in September in New York. We did this program last year. We'd love to have you all there. And very importantly for this group, we are developing an AMR simulation that we hope to launch at UNGA. And we're looking for help and partners to pull that together. Our simulations, which are run by the FP Analytics research team, pull together groups of people to role play scenarios that are impactful and work through these problems. They're kind of like war games, but they're the opposite of war games. We call them peace games, to try and come to solutions. They're very in-depth. Everyone who participates in them comes away thinking, oh my goodness, we've learned so much. We did this a few months ago at the Munich Security Conference on a bioterror simulation. We did one on space governance at the Paris Peace Forum last November, and we're looking to do this on AMR specifically at UNGA in September. So please do talk to Zach about that if you're interested. And you can learn more about our events at foreignpolicy.com/events. I want to also thank the amazing FP Events team that pulled this event together. And I really appreciate all their hard work. It really went flawlessly. Now please join us for cocktails. Thank you so much for your patience.